Thanks for the invitation. It has been a pleasure being here. So let's start with the presentation. This hasn't been an easy topic because it's quite broad. So I'll try to give you some practical advices how you can use this in your practice. So just a bit about myself. This is Guy's Hospital where I work. We work on the 22nd floor. I'm now also the coordinator of the European Union project about training healthcare professionals about lichen planners and oral potential malignant disorders. This is a free training, so anybody can attend. They just need to speak to me. So, questions to ask when we see a patient about recurrent oral ulceration or just oral ulceration is, what does the patient mean by ulcer? We have patients that come to us and say, oh, I have multiple ulcers. And we ask, can you point to one? And there is no break of epithelium, so there is no ulcer. Let's try to see, is this really an ulcer or not? When does the patient start having ulcers? If it's quite in a young age, we think most of the time recurrent after stomatitis. How are the frequency? How long do they last? And where is the common area? So for example, ulcers in the soft palate are much more associated with major AFTI. Are the ulcers preceded by blisters? Then we can start thinking about vesico-bullous disease, pemphigoid area. The shape, if it's regular or not, related with menstruation and changes in the size and degree of the ulceration over time. So this was an interesting case, just to point to you. So 73-year-old woman presented with 1-year history of a persistent ulcer. No extra-oral abnormalities. So, but when you look at you can see on the homogeneous yellow ulcer. And that from a clinical appearance looks okay because it's quite homogeneous and well circumscribed. But on the lower part, you can see some white dots. So you call this kind of speckle, mix of white and red. But on the upper part, which you cannot see it, it's when it's hard on palpation. So this patient had had multiple topical treatments in other places. So what question is where to biopsy? So my advice in this case is do several biopsies, because if the biopsy was done only on the lower part, as shown in this case, it will only show myelodysplasia and the case would be completely different managed. But because it was also done on the upper part where it was hard on palpation, so that's a very serious feature in terms of malignancy, showed early invasive cancer. Okay? Just to alert you about persistent ulcers, and hardness on palpation is quite a serious feature of malignancy. So recurrent single ulcer, always look for traumatic factors. Is there anything sharp? Any chemical device? Sometimes patients leave an aspirin or other medications close to a specific area. Infections, it was discussed here before about the impact of syphilis. We tend to see occasional tuberculosis, but it's quite rare, and deep mycosis. So recurrent oral ulceration, always think about what is the systemic, the pointer, okay, thank you. What is the systemic feature which we could be associated? We've talked about the vesico-bullous disease. I'll mention a bit later how do we tend to manage from a topical, but also a bit from the systemic perspective. So the typical patient that comes to us, for example, with recurrent ulcers in the mouth, which denied any blistering associated, we tend to do a range of blood tests. We start by doing full blood count to check for anemia. We do B12, ferritin, and folate for any hematinic deficiency. We tend to do sometimes CRP and ESR, especially if the patient reports some gastro symptoms, in which we can correlate high level of inflammation with anemia or lack of certain hematinic deficiency, and then go ahead with the colonoscopy. And if we suspect, for example, we most likely are not successful treating with topical treatments, we may use systemic medication, which we'll talk about it. So looking to this picture, what do you think would be, especially in a patient complaining of fever associated with this kind of ulceration? Okay. Herpes, yes. So always remember, is this ulcer caused by trauma Is this part of a systemic condition like Behçet's, secondary to ulcerative colitis, Crohn's disease? Is this part of a hematological disorder? Is this associated with skin changes? Do these questions to the patients. So this is the most common type of oral ulceration called recurrent after stomatitis. We see the major ones here on the posterior soft palate, and these tend to be the most difficult ones to heal, because this is the patients who present to us with 1 or 2 single ulcer. We have to question in a certain point, is this related with cancer? And sometimes we have to do a biopsy, but the healing process can take sometimes up to a month. Then the second one, when patients a bit more older, present with multiple, and this is quite rare, where they have this kind of big, and they call herpetiform, not because it's caused by herpes, but because it resembles, looks like herpes. So this is the topical, we tend to use it most of the time. So this is used for the recurrent after stomatitis, but also for example, patients with lichen planus oral involvement. So we are part of a team that we work with oral medicine, but we also work with other gastro and dermatology close by, especially when there is skin involvement. So patients presenting, for example, from a lichen planus perspective or recurrent after stomatitis with multiple ulcers, we tend to start with betamethasone 500 micrograms, 1 tablet in 10 ml of water, and use as a mouthwash. If you look to the evidence, there's many publications related with systematic review and what is the best topical, and there is a Cochrane group looking to detail for this, and we could not identify which one is superior to them. So our approach, it tends to be based on the strength, which one is stronger on the topical steroid. So we tend to start with this one, or betamethasone or prednisolone. If it is 1 or 2 single isolated ulcer, we tend to ask the patient to use a topical steroid spray, fluticasone 50 micrograms, where they can apply directly on the ulcer twice a day for about 2 weeks. The problem we have with oral management is, apart from these two, all this is off license. So we need to explain to the patient the availability of topical treatments to the mouth is limited, so we are using treatments that are designed to be used in other parts of the body, especially on the skin and nose. One we tend to use quite frequent is this called flixonase nasal. So this is fluticasone propionate 400 micrograms. This is designed to be used to the nose, but as an off-license medication, we ask the patient to break, mix with water, and use as a nystatin 1 milliliter. For persistent more ulcers, and this is quite effective, is the Dermovate, which is the clopidogrel propionate. This is also quite useful, for example, on lichen planus or pemphigoid or pemphigoid in patients with very strong desquamative gingivitis. Okay. On systemic, we tend to use as first line of treatment for recurrent after stomatitis colchicine from a preventive perspective. And then we increase the strength. What we tend to tell most of these patients is the patient who guides the treatment. If they present with only ulcers in the mouth, they can say, look, I don't want to have the side effects of these medications. I can manage well, it's not ideal, but I want to use something when the ulcers are there. When we have the second group of patients saying, this is impacting strongly on my life, it's difficult to eat, I'm losing weight, I need something to prevent the attacks. So we tend to go more into this medication. And this is some of the topical advices. You can look for leaflets in the British Society of Neuromedicine. This is kind of open to everybody. So this is the principle of the fluticasone flixonase 400 micrograms, the same. And this is the Dermovate. One of the most used ones for lichen planus, pemphigoid, and pemphigoid, especially when I was mentioned the desquamative gingivitis. So I tend to ask the patient, especially on the gum region, first they need to see the local dentist and have a good care of the gum disease. So that's the first advice you should tell them. Look, and many of the pemphigoid or pemphigoid conditions, the level of activity reduces quite quick, just with a good oral hygiene and dental treatment. Then we try the topical treatments I was mentioning, the mouthwashes, and then to apply on the gums or local ulcer, you ask the patient to dry that particular area and put the clopidogrel. And what we tend to use it is to mix with this paste. Oral base, it just helps to the dermovate to stick in that area. So we tend to use as an ointment. And then we tend to say to use around twice a day for about 2 weeks. But the management can vary. Some patients then use once a day. They'll find the most useful one. But we kind of strongly encourage to rinse them out after. And we explain this is an unlicensed medication. So when exploring, where is the ulcer coming from, always ask about, do you have ulceration in any other parts of the body? Genital region, eyes. And this brings us to the group of the Behçet's disease. When I was working in Birmingham, we used to have also MDT unit just for Behçet's disease. So this is what we call the Silk Road, where it's more common to see these patients. And when we suspect about Behçet's, we tend to ask the HLA-B51 genetic test. So the diagnostic criteria has changed. This is the most common one. Ulcers in the mouth, genital ulceration, but also eye involvement. And they also have the multiple other tests. The management. So when you're part of the MDT, patients goes to different clinicians in one appointment. So he sits kind of 20 minutes with oral medicine, 20 minutes with ophthalmology, neurology, and then comes around, and then we sit all together for the overall management. And we see, it's quite explained well before in the other lectures, see the patient as a whole. So if it is kind of from a systemic perspective, we go quite quick for systemic medication. We may include the colchicine, short course of steroids, azathioprine, mycophenolate. But if it is just for an oral involvement, we use the topical treatments I mentioned before. And for a preventive measure, we tend to use the colchicine, which is quite useful. So this is another syndromes we tend to come across occasionally, which is kind of similar to Behçet's, but is not Behçet's. One is the mouth and genital ulcers. So they have mouth and genital, but they don't have the eye involvement. It's not completely understood if there's an autoimmune basis, but the treatment is also based on topical approach. So the other is oral and genital ulcers. We don't have the eye involvement. We used to quite see this on the Behçet's clinic, where we kind of don't fit with the typical Behçet's, but they say, well, you have recurrent ulcers in the eyes and genital, but no other typical condition which could raise vesical bullous or any other condition. So explore these scenarios. And this is quite rare and infrequent, the periodic fever and after stomatitis, pharyngitis, adenitis, we call FAPA. Quite common in early age. So ulceration secondary to connective tissue disease. You all know about erythema multiforme. So most of the time, this is the typical presentation we tend to see, affecting mostly the mouth. And this kind of ulceration and crusting on the lips is quite pathognomonic or common in erythema multiforme. The question is now how to reduce the attacks of the oral ulceration and how to identify the main trigger. If the patient tells us a story about a certain medication he has started, it's quite easy. But most of the times, we tend to correlate with herpes. We may do the swab and ask for herpes PCR, or we do the blood test for IgG and IgM, and may give or not a positive result. But one of the first lines we tend to do it, before jumping to long-term immunosuppressive medication, is to put the patients on prophylactic acyclovir 400 milligrams. It tends to in a first stage, reduce the number of attacks. And when it's controlled, then we start asking to reduce its frequency and then even to stop. Lichen planus. You all know about lichen planus. This will focus mostly in the eye involvement, in the mouth involvement. So this is the kind of the typical presentations. White striae can be associated with erythema and ulceration. So this is the typical desquamative gingivitis. The approach is the similar. Ask the patient good oral hygiene, ask to see the local dentist, try the topical steroids first we were talking, the mouthwashes, the spray, and the cream or ointment tends to work quite well here. Many times it may not be enough, and we have to go into systemic medication. And even the use of systemic medication, there's no true strong evidence which one should be first or not. We tend to particularly like to use interesting hydroxychloroquine. It's quite mild in terms of side effects comparing with azathioprine and mycophenolate. There's some debate because the hydroxychloroquine is part of the antimalaric medication, and when you look to the evidence, antimalaric can be associated with lichenoid reaction, but tends to provide quite good responses, and in terms of management, it's much easier when you compare with azathioprine or mycophenolate medications. So we tend to use this kind of scoring that was developed in our unit to assess what is the improvement. How can we measure with numbers that this patient is better? Lichenoid reaction, most of the times, can be triggered by medications. To explain to the patient that this lichenoid reaction intraorally is mostly triggered by the medications is quite difficult. We tend to ask within 6 months of starting medication. But most of the times is associated with amalgams or close to a particular feeling. Now, how can we diagnose if it's a lichenoid reaction or lichen planus? From the histopathology perspective, and we have the expert here, sometimes
4 minutes more.
Okay. Sometimes it may not be easy to make that distinguish. So we go most of the time sometimes to patch testing. It gives us a certain confidence, and then to ask the patient to replace this. So this is one of the books I coordinated. If you want to learn about more lichen planus and premalignant conditions, it's available. Oral ulceration as part of systemic lupus, you also know, but in this case, the discoid lupus, I just wanted to show it. The management, again, is from a holistic perspective, but it can't look like a lichenoid reaction. But look to the appearance, this kind of ring around the redness area on the buccal mucosa, and tends to be quite unilateral. Oral cancer and oral lichen planus. It's kind of, we always tell the patient, and we have to write a letter showing an evidence that we have told the patient. We have cases that went to litigation that say, oh, nobody informed me about this. And we have to instruct the patient how to look for suspicious conditions. And these are worrying areas like a dense white patch. We call speckle, these mixed areas. So this is the overall management. We tend to do it from mild, just to topical. Moderate, we may use the topical and start with systemic. And then systemic, we tend to use most of the time hydroxyl, azathioprine, mycophenolate. Sometimes for a persistent ulcer on lichen planus, we may go for steroid injection, but we always do a biopsy prior to make sure it's not cancer related. Immunobullous disorder, during these days, we've talked a lot about this perception. From the topical perspective, it's very similar, but that's when we work close to dermatology to understand if there's skin or not involvement. We see many patients in that clinic with just mouth involvement, and the approach is quite similar. First, if it is gum involvement, ask them to go to the local dentist, and you need to pass this message is, even if it hurts about the oral hygiene and cleaning, they'll have to insist because they have to break the habit or the cycle that inflammation on the gums will make it the pemphigus or mucous membrane pemphigoid quite worse. And then we go to the topicals we discussed before, but also we tend to give short course of steroids. We go to ASA, mycophenolate, and more we are moving. I know you use quite biologics quite usually. We tend to use it more on the third line of approach. but slowly you are moving to the biologic, especially infliximab. We like to use it on the MMP, but most of the times it's a cost related, because this is funded by the NHS.
1 minute more.
That we're finishing soon. So this is one of our publications about graft versus host disease, where we compare all the topical treatments, and we could not say which one was better than the other, and you can explore. The paraneoplastic is quite difficult and challenging, the diagnosis, so we tend to ask for red blur indirect immunofluorescence when explored, but the presentation is quite similar. And to finish, always explore hematological disorders. Is this related with some gastric symptoms, celiac disease, bowel problems? And this is a condition we're quite specialized in our unit, called orophacial granulomatosis, presenting with lip swelling, but also quite ulceration on the sulcus. And the interesting is, can be associated with Crohn's or not, so we have to explore this quite easily. But the first approach is always this diet, and brings amazing results, a cinnamon and benzoate-free diet. And this can quite easily regress if they do this quite close, and we work with the dietitian on this medication. We go for steroid injections, suspicious lesion, just to alert you that an ulceration that could be sometimes not so bad when you look carefully is in fact cancer. You may focus, oh, this white patch is related with lichen planus, let's do biopsy here, but explore also other areas, especially here. So there's kind of a big cancer in this region. So that's the free healthcare I was asked to coordinate from the European Union, OPMD. It's access to everybody. It's open access. You can explore about management, about lichen planus and other potential malignant disorders. So to finish, key factors. Always ask about ulcers. Is this related with some systemic or not? Is there any skin, scalp, genital, eye, bowel abnormalities? Try to reach the correct diagnosis, because this will definitely change the overall management. Key aspects when you're investigating the ulceration: the age, when it started, medical history. We are getting now interesting more and more patients, elderly age, who are not telling us they have HIV and stop taking the medication. Systemic involvement, family history, and biopsy if required. Summary: oral cavity can provide a window to other conditions. Oral manifestations can be a sign of some systemic manifestation, and therefore it's quite important to reach the right diagnosis. Any questions? Let me know. This is my contact if you want sometime soon.